good evening. Welcome everyone to Ask the Experts, Living Well with Heart Failure Patient Virtual Question and Answer. This free webinar hosted by UHN will span the scope of living with heart failure, including diagnosis, treatment, appointment and device management, mental health, and support for both patients and caregivers. My name is Heather Cartwright, and I am a patient with heart failure. I'm moderating the questions that have been submitted earlier. I have been living with a condition called ARVC for over 30 years and with heart failure for the past 8 years. Joining me as my co-moderator is Sheila Ross, and she's going to be moderating the live questions that will come in through our chat box. Sheila lives with congenital heart disease and has spent the last 18 years in leadership roles, creating a community where patients can support and learn from each other. Our experts are Michael McDonald, a cardiologist at PMCC and medical director of UHN's Advanced Heart Failure and Heart Transplant programs. Mike, if you're on, you give us a wave so we can see who you are. He's also joined by Dr. Robert Nolan, the director of the Cardiac eHealth and Behavioral Cardiology Research Unit at UHN. And Robert, if you're on, give us a wave.
Sure. Rob's fine, by the way.
Okay, Rob, thank you.
Great.
And we're also joined with Tina Carrier, the Medley nurse coordinator at University Health Network. So give us a wave.
Welcome, everybody.
So we have three sections that we're going to cover tonight. Thank you for submitting your questions in advance. And remember to submit your questions through the chat if you'd like to ask as we go along. Some of the ground rules are that we'd like to share airtime. We want to create a safe and welcoming environment for everyone. We're going to try to stay on topic and on time. And remember that we're all equal. And so we're going to try to leave our rank at the door. So let's begin in our first area. It's heart failure awareness. So this is the first of our pre-submitted questions. The first question is, can there be more public education on congestive heart failure? If I say I live with congestive heart failure, I'm often met with, so when did you have a heart attack? So let's open this to our experts to answer. How about Dr. McDonald, would you like to kick this off?
You betcha. I saw this question and it's a really good one because people or patients that we encounter have this to say all the time that, you know, the so-called general public or lay public thinks that or have this impression that heart failure means you've had a heart attack. And of course, those people are become familiar with the term heart failure know that it's so much more. So that's just one example that somebody had put together as a question that speaks to the broader issue of having to do a better job as a community of educating the world, educating the general public about what heart failure is. And I think people have a good awareness of what a stroke is, what a heart attack is, what different types of cancer are, maybe less of a crystal clear idea of what heart failure as a syndrome is, particularly when you consider that heart failure is extremely prevalent in Canada. So if we're a population of 35 to 40 million people and growing, we can expect that just about a million Canadians at any one stage are living with heart failure. So clearly a lot to do. This is not a rare condition or a rare syndrome. In recognition of this, of the need to really promote the discussion or the dialogue around what heart failure, heart function, heart conditions are, there is a groundswell of an attempt to try and get this into the public space. And we've seen that very successful campaigns and grassroots developments with the Heart Failure Awareness Week. So For those who are not familiar, for the last few years, the Canadian Heart Failure Society has put together a Heart Failure Awareness Week in collaboration with the Heart Life Foundation, which is a patient-led promotional organization to focus exactly on educating the public on what heart failure means. So a lot of work to do, but a lot is being done, and it's really nice to see this so-called grassroots or groundswell movement to get the public educated and up to speed. So maybe I'll leave it there and see if other people have comments.
Okay, great. Thank you very much. So let's go to our second question. So we'll go back to the slide. How can we lobby to get more cardiac units in hospitals outside of major centers? So another pre-submitted question, and if one of our experts wants to jump in. How about we go back to you, Michael? Maybe you could round out the topic.
Yeah, so this is a good question. It gets at the issue of policy and allocation of resources at a provincial level. And I think what people recognize is that it can't all be like an exclusive nightclub where you've got, some patients getting into the heart failure center, the expert centers at big teaching hospitals, for example. And over the last few years, we've seen a better job, although still not full service delivery across the province, but a better job at least of recognizing that in community centers, there needs to be some expertise at managing patients in a multidisciplinary heart failure clinic environment, and certainly in the outpatient setting. And that really means having a collection of specialist clinicians like nurses and primary care physicians or internists or cardiologists that are really going to champion heart failure care and deliver that as a bundle and have close ties to hub centers. So the so-called hub and spoke model, where you've got a big center here with all the tricks and tools and resources like cardiac surgery, for example, and then smaller feeder centers that can still deliver excellent care locally and have these formal ties. So it's another work in progress and a recognition of a gap that exists, but it's still not good blanket coverage of the whole province. And in fact, we're still trying to get a line of sight or a sense of where the gaps are in the province. We're doing an okay job in some bigger centers, but there are still clearly places that don't have formalized heart failure care. So again, part of Heart Failure Awareness Week, or the ongoing journey to educate the public about what heart failure is as a diagnosis, also should include discussion of how we navigate care for patients in the Ontario health system.
So, and if I might add too, being a Medley coordinator and Medley being a remote heart failure monitoring tool program, this offers, one of the spokes that Michael spoke of when he was saying about the wheel, because with the program, we can actually remotely monitor patients outside of the city, outside of the central, of the bigger hospitals. And we can use that as a tool to try to at least increase the access to care that heart failure patients have.
Great, thank you for those responses. So I'm going to now send the moderating questions over to my co-moderator, Sheila, for any questions that came in online.
There we go. Okay, the first question is microvascular coronary disease a type of heart failure?
Maybe I can take a swing at that. That's a really sophisticated and challenging question, because the answer is maybe. And I think what that's getting at is the idea that some people have evidence when we do cardiac testing of insufficient blood supply to the heart. We call that ischemia. Now, usually that's because of a critically narrowed artery or multiple critically narrowed arteries that supply blood to the heart, but not always. Sometimes the disease, or what we think of the problem, is in the small, tiny little branch blood vessels that are sometimes hard to see with the naked eye when we do our standard cardiac testing, looking at or imaging, looking at the arteries of the heart. So we infer that there's a problem with the small, tiny blood vessels that we can't see with the naked eye very well. And there's some thought that maybe that's really prevalent as we get older. It might be more prevalent in patients with some conditions like diabetes. It might be more common or prevalent in women in particular. And that as we age, we get this stiffening of the heart that can lead to heart failure in some patients. And so there are a lot of theories out there, some research that really points to microvascular dysfunction, which was the question raised, as a potential cause for some types of heart failure. So it's a question that gets at the frontiers of science and trying to figure out exactly what's happening at the body, particularly as we get older, that can lead to heart failure. Sometimes we know, and sometimes we just don't know for certain.
Thank you. The next question is, this is a good one. How do I convince my parents that the reason that I have congestive heart failure is not diet or exercise? The cardiologist has no real idea why it happened to me, but my parents keep insisting it is these things.
Well, I'll take a stab at that one too. And it's true that some people are born with risk factors for heart disease or develop risk factors for heart disease over the course of their life. But there are other patients, many in fact, in some estimates almost half, where there are cases we don't actually know what causes the heart muscle dysfunction that leads to heart failure. So in some patients, it's incredibly frustrating for people living with this and for the care providers, for the different professionals looking after the patients, not to know clearly why somebody developed heart failure. You do everything right, you exercise well, you eat well, you don't smoke cigarettes, all the things that we're taught we're supposed to do, and yet some people will develop heart failure for reasons that are poorly understood or poorly defined. As science goes and as we learn more, we're recognizing that genetics play a bigger and bigger role than we realized before. We're probably just scratching the surface, and in 10, 15, 20 years, we'll know a whole lot more about the genetics and the linkages of biology to heart failure. And sometimes we'll discover new toxins or viruses or environmental factors that contribute to heart failure in some vulnerable people. So not that your parents are misinformed, for whoever asked the question, it's just an incomplete understanding of why some patients get heart failure.
Thank you very much. The next question's for Tina. Is Medley available for remote and rural communities?
Well, at this point, Medley, if you are connected to the heart failure clinic, then currently you can be part of Medley. But I think that the program is being expanded, but just currently, if you are connected to the clinic and you have a heart failure physician, then you can be a part of Medley. It is a remote monitoring, so as long as you have internet access and you have access to a smart phone or tablet, you can do Medley from anywhere. You don't have to be in the city.
Thanks a lot, Tina. Okay, now we're going to go back to Heather for the next section.
Okay, well, great. That was a good segue with some great questions. This section is about managing heart failure and your health. So lots of questions here. If we don't get through some of the pre-submitted questions, we'll move on to our final question period. And if we have time, we'll come back. And we'll also come back to questions that are submitted online. So first question, how do you decide how much water is good for you to drink each day if you don't have swelling or shortness of breath?
This is I'll take a first run at this, and then certainly Robert or Tina can can add their 2 cents as well. But this is a moving target for patients, and no two patients are likely going to be the same. So there are some people with pretty significant heart problems or heart muscle problems that actually don't develop a lot of issues with fluid retention, which is one of the main symptoms or features of what we call congestive heart failure. And other patients, for reasons that maybe we don't understand fully, have a tendency to really retain a lot of water. And that water can be retained in ankles, where you see swollen ankles, in the abdomen, where you see a swollen belly. For some people, it's in the lungs, where breathing is short and there's difficulty lying flat because of fluid buildup in the lungs and the spaces around the lungs. So it's very difficult to have a one-size-fits-all solution. And it's also difficult to predict in a month or a year from now how much fluid restriction is appropriate. So if someone is fairly well and they haven't been hospitalized and they don't tend to retain fluid, that individual may not need a fluid restriction at all. In contrast, somebody who's been in and out of hospital or the emergency department because of recurrent fluid retention, those patients tend to need a restricted fluid intake as a general statement. And of course, we kind of tailor that to what we think the individual needs. If somebody is 6'5" and 280 pounds, that person is probably going to have a more liberal fluid intake for their body's needs than somebody who's 5'2" and 100 pounds. Sorry for the non-metric units, but that just gives you a sense of how individualized we have to make this.
Okay. So our next question, what are the limits to strengthening the heart through exercise?
Well, so it turns out, so if you go back in the olden days, way back 30 years ago or so, it was dogma or widely accepted that you had to rest. If you had a heart attack, bed rest was what you needed. If you had bad heart failure, bed rest was what you needed. And then through the 80s and 90s and the aughts, the last 20 years or so, it's been very well recognized that exercise is good for the heart. And the devil is always in the details, however. So it's important that you have an appropriate exercise prescription. And when you have a careful conversation with your care provider, it's important to try and understand what your exercise prescription is. What is the right amount of exercise I can do? And in the most basic level, one of the things we want to avoid is working exercising to exhaustion. So we don't want people overdoing it so that they're using muscle groups and pushing themselves to exhaustion, because that's probably overdoing it. But working up a sweat, the ability to still have a conversation while you're exercising is just rough guidance for how much exercise is appropriate for most people. The exception to the rule might be patients with very advanced heart failure or people who've just gotten out of hospital. We do need to see a period of being stable where you're able to carry out your ordinary activities without too much or too many symptoms. We want to see people relatively stable that they can participate in their ordinary activities before taking on an exercise prescription. And because it's nuanced, and again, one size doesn't necessarily fit all, we make good use of our colleagues in the cardiac rehab program. So we readily refer our patients to an exercise rehab or a cardiac rehabilitation program where they have experts that do this all day, every day, and can tailor an exercise prescription to an individual's needs. And we see real gains in quality of life and activity tolerance and all the other important stuff.
Okay, so I think we now have a question for Rob. What mental health practices do you recommend to reduce the anxiety and depression associated with living with heart failure and the limitations on one's lifestyle?
Yeah, that's a great question. I think that the best starting place is to think in terms of what are your priorities for living well? And I would think in terms of the types of activities, you know, is it spending time with loved ones? Is it doing a personal project that gives you a sense of satisfaction? Is it, you know, being able to have moments where you just feel calm and at ease? Is it fulfilling your roles and responsibilities? Is it pursuing a sense of excellence with your knowledge or skill of a favorite activity? So I would focus on those and then schedule those types of activities in, you know, and that's the best buffer for any anxiety or stress or challenge to our mood that any of us can have. Other strategies, though, you know, deal with those challenges of stress, anxiety, depression at the source. And there are some really excellent resources. Some of them are on the education website. Others are resources that we're developing in the context of a trial that's called Odyssey VChat. But essentially, there's some really excellent strategies to interrupt, you know, the kind of self-talk that sustains, you know, when we're feeling at odds, you know, or stressed, depressed, anxious, and to transform it. And if there's one question I would suggest, you know, to ask ourselves in those moments, it would be something like, even if I am in a difficult situation, what's the best way that I can respond to it? You know, so that I can bring out the best of life that, you know, I might enjoy. So that would be, I think, my response in a nutshell.
Great. Those are all really helpful tips. Thank you. So we'll go back to our screen and we'll go to the next question. Okay. Can you reverse any aspect of heart failure, or is it just a condition to be managed?
I can give you my perspective on this. This is a fascinating question. So in general, you know, heart failure is a continuum from risk factors to problems with maybe the function of the heart to developing symptoms. And we say that once you have a diagnosis established, then it's really a condition that must be managed. That's the rule that applies for most situations or most patients. And management in some patients is very straightforward, doesn't require a lot of heavy lifting, so to speak. And in other patients, of course, we know that's not true, requires a multi-pronged approach to keep people living well and feeling well and staying out of hospital and doing what they need to do. So the symptoms of heart failure can be managed, and we have really good tools to do that. What we see in some patients is that our newer generation of medications, in combination with our tried and true older generation of medications, can actually lead to really dramatic improvements in heart function in some patients. And we're now starting to think, and this is a very optimistic statement, but we're now starting to think of heart failure for some patients as a condition that could go into remission. Now, that's not true for everybody. It's still not the rule, but it's something that we're working towards because we do have examples where all of the interventions work together synergistically to improve the heart function and lower future risk. If you've been labeled or diagnosed with the condition of heart failure, it's something that's with you. It's a risk that is carried through life. And in general, we think about managing those symptoms that are associated with it. But there are certainly cases where the condition can be treatable or even reversible, particularly when we know the underlying cause, we can target the underlying cause, and it works well.
Tina, do you have anything to add on this topic?
Yeah, after what Mike said, I think that, yeah, and there, we also have so many more tools too, you know, Medley being one of them, where if we can keep you by monitoring you closely and being able to titrate your medications and early interventions should you start to have heart failure, these are all tools that we can use to keep your management at your optimal management. Yeah. So and I find it frustrating for some patients because they do everything they think that they should be doing, and so, you know, and their heart failure function is not getting any better. But, and as Mike pointed out, sometimes that's just, you know, we can just keep you at the best that you can be.
Great, thanks for that input. It's encouraging to hear that there could be some optimism of having this condition well managed enough to be in remission. That's new to me. That's excellent. Okay, last question on this slide is, what factors go into predicting the life expectancy of someone with heart failure? So let's go back to Mike. Maybe you could kick that one off.
Yeah, this is. I want to just, I can't help myself but dive in because there's a running joke around me as a teacher in heart failure, and Mike's probably doesn't remember it anymore, but it used to be that if I was in a bad mood, I would ask for 50 independent predictors of risk, and if I was in a good mood, I'd only ask the residents for 20. So no pressure, Mike.
Yeah,
so for those of you to our group, this is Dr. Heather Ross, who just weighed in, and esteemed cardiologist and heart failure specialist and colleague of Dr. Michael McDonald. So let's hear them, Michael. Thank you.
Yeah, the colleague and former trainee of Dr. Ross. So I've been on the receiving end of having to list as many predictors of prognosis as possible, but in the broad strokes, when you have a diagnosis of some type of cancer, again, this goes to what's in our public perception. If we hear about certain types of cancer, there's a good chance that the cancer specialist can predict prognosis with good accuracy. And that's why you hear somebody's been diagnosed with early stage cancer or late stage cancer. That means, you know, understandably two different things, and we can sort of pinpoint the prognosis reasonably well. Heart failure is such a broader spectrum it's a broader condition, it's a broader spectrum of illness for many patients. No two patients are the same, and the patient's journey is so fluctuating or so up and down that it can be hard, it is hard to draw a straight line from point A to point B and figure out what that journey is going to look like, when people will get sicker, and what prognosis really means. So people have been really trying to get at this for years, and there are many studies that have what we call risk predictor models, where you input patient data into a math equation and it spits out a probability. The trouble is that's generated from, you know, tens of thousands of patients rather than the individual patients sitting in your office in front of you. That said, there are some general things that we look at. One of the most powerful predictors is how symptomatic somebody is. So if someone's cruising along in fine style with really little symptom burden, or able to carry out their regular day-to-day activities reasonably well, that's a very favorable thing. The game changes a little bit when symptoms become harder to manage, more severe, when the heart function can deteriorate and the other organs of the body can be affected, whether it's the liver, the kidneys, the brain. And then by the time we see patients coming in and out of the emergency department, in and out of hospital, those are signs to us that something's changed, and we may need to step up our interventions, get a little more aggressive, because that impacts prognosis. So it's more of a journey, and where an individual is on that journey that drives it. So, you know, that's sort of the broad strokes, and of course there's a lot of nuance in there depending on the type of heart failure, patient age, other heart rhythm problems, et cetera, et cetera. So there are some things that we can do to put a finer point on it, but it's very different than other disease conditions for sure.
Okay, thank you. So we'll go back to the slide and move on. How long do mechanical aortic and mitral valves last?
So mechanical valves can last lifelong, essentially, if they're the right size for the patient and there are no issues or complications with the valves. So mechanical valves are very, very durable. And people raise that question because the alternative to a mechanical valve, which is exactly as it sounds, it's a metal valve between two chambers in the heart. The alternative to a metal valve is a tissue valve. There are different types of tissue valves, but as the name implies, it's not made of metal, it's made of some kind of connective tissue. And tissue valves wear and tear and get a little bit more beat up through their life cycle, so that patients who have a tissue valve operation might need a second operation in the future after about 10 or 15 years. Again, so that's the rule. There are exceptions, of course. So the tissue valves can get a little bit more beat up, but there are good reasons individuals talk to their surgeons and choose to have a tissue valve as opposed to a mechanical valve. But in terms of wear and tear, a mechanical valve can last a long, long time, decades.
Okay, thank you. All right. Here's a question. I have an ICD, so this is interesting to me too. When do you turn off an ICD?
So an ICD, for those who may not know, stands for implantable cardioverter defibrillator. And really, it's a type of pacemaker. It's a bigger version of a pacemaker, and it does two things. It's a wire that sits in the heart attached to a computer and a battery, which is implanted under the skin, usually under the collarbone. And it does two things. It paces the heart when the heart goes too slow. So the so-called pacemaker function, it watches if the heart drops below a certain rate, it'll just stimulate the heart to pace. And that's a painless thing that patients usually don't know is happening to them. The other thing that a defibrillator can do as a safety feature is just sit there and watch for really dangerous or fast heart rhythms. Some patients with certain conditions are more predisposed or at risk of developing a racing heart rhythm. And if the heart takes off and races abnormally fast, we call that some certain types of arrhythmia that could be life-threatening and in some cases lead to a collapse. And a defibrillator implanted in the body will recognize that. It will charge up and deliver a shock. Sometimes people have passed out and don't recognize that they've had a shock, and other times they're aware of it. The defibrillator goes off and it can be uncomfortable, distressing, painful. So the decision to turn a defibrillator off is an individual decision. Some patients may experience a shock and then decide, you know what, that's not for me. I'll take my chances. And if I were to someday pass away in my sleep from an arrhythmia or collapse from an arrhythmia, then that's fine. I will take that over receiving a shock, which could be distressing. Typically, those decisions are made by patients as they approach their end of life, when they have other illnesses, for example, terminal illness that takes over and changes their prognosis for reasons that have nothing to do with the heart, or if heart failure were to progress to a very advanced stage, where patients may not want to experience painful shocks from a defibrillator towards the end of life. It doesn't mean that turning the defibrillator off stops the heart. It doesn't mean that the heart won't beat. It doesn't mean that the heart won't pace if it goes too slow. It just means that if there's a dangerous arrhythmia, the device will ignore it and not deliver one of those shocks. So you can see this is a nuanced discussion between patients and their providers. It's often a very highly personal decision, and it requires a number of conversations and a number of inputs from trusted care providers. So there's more on this. If you go to the Heart and Stroke website, they have a very nice section on that. The Ted Rogers patient engagement site has a section on that. So and this is a conversation that patients should have with their families and loved ones, and because they may not always be able to speak for themselves or voice their preferences for themselves at different stages in their life. So tough question. It's a big one, and again, not a one size fits all answer.
Okay, thank you. So remember, put your questions in the chat. We're going to go back to the chat now, and I'm going to hand over the reins to my co-moderator, Sheila, to take some questions from the chat.
Yeah, sure. This I think is for Mike again. Please expand on the implications of arrhythmia for heart failure and vice versa.
So I use the term arrhythmia very broadly or very generally. And arrhythmia is not a heart attack. Again, it often gets misrepresented or misunderstood as the same thing as a heart attack. It isn't. Arrhythmia just means that the heart has gone out of rhythm. It's beating abnormally, and there are some kind of heart rhythm disturbances or problems that are like nuisance problems that patients, they don't threaten your life, they don't make you particularly unwell, they're just kind of a nuisance, and you may need to take medications to get it under control, or see a specialist cardiologist known as an electrophysiologist to have an ablation procedure where they find the short circuit causing the arrhythmia and just ablate it and effectively cure it. I consider those, and my colleagues would consider those, nuisance heart rhythm problems. An example of a nuisance heart rhythm problem would be a supraventricular tachycardia, for example. There are other heart rhythm problems, something called atrial fibrillation, which is extremely common when you have any kind of heart condition, particularly heart failure. Atrial fibrillation itself is rarely life-threatening in the short term, and that's a condition where the top chambers of the heart race and the bottom chambers also race to try and keep up, and it can lead to fluttering and irregular heartbeat, and what some patients experience as palpitations. And about 30 or 40% of patients with heart failure will have atrial fibrillation, and the risk there is that it can predispose patients to feeling unwell, retaining more fluid, or developing blood clots that could lead to a stroke. And then there are the most dangerous type of heart rhythm problems, something called ventricular fibrillation or ventricular tachycardia, which could lead to a cardiac arrest or a collapse in some patients. So that's where there's a problem in the bottom chambers, the main pumping chambers of the heart, known as the ventricles. There's usually an electrical short circuit, and the heart takes off and races, and that can lead to a collapse. It's that rhythm that people are most concerned about when we're thinking about putting in a defibrillator for prevention. We want to prevent that from running away and causing problems. So it's a big catch-all term, the term arrhythmia. It means many different things, and I've just given a couple examples of common heart rhythm problems that you might encounter when we're talking about heart failure.
Okay, thanks, Mike. This is the last question in this section, I should say. It is, I have an ICD under my armpit where the wires go around the heart. Which type of defibrillator is considered best, and how does a doctor determine which is best to use?
Yeah, again, a really nice question, a highly technical one. So I think what the question is getting at is that most defibrillators act like pacemakers, where there's a wire physically through the vein that leads to the heart and attached to the heart muscle on the inside. There are other types of defibrillators that are relatively new, just within the past few years, that go under the armpit or by the ribs, under the skin, and they sit outside the chest wall, and they do the same thing as a regular defibrillator will do. What they won't do, however, is pace the heart reliably. So they don't have the ability to prevent the heart from going too slow. It's just there to prevent the heart from going into a dangerously fast heart rhythm, and it can deliver a shock. So the technology is changing. The reasons your care provider may recommend one over another will evolve and change over time. It's good to have options. It's good to discuss whether or not you might qualify for one or the other when it comes time to having these conversations with your specialist, for example. Okay, great. Thank you. We're going to wrap up that and move on to heart failure research. So on this first question, I'd like to invite Tina to answer it. And I'd also like to invite Dr. Ross to weigh in at any point, since we're lucky enough to have her on the call. So Tina, what is the status of research on women living with congestive heart failure?
Well, unfortunately, that I'm actually going to refer to Dr. Ross for this, because she would actually be able to be the best person because she, Dr. Ross, please.
Sorry, Heather, could you just rephrase the question for me?
Yeah, what are the developments that are currently happening for congestive heart failure for women? Research in regards to women with this condition.
Well, that's it. I'm actually pretty sure Mike could probably comment on this as well. But what I would say is that what we have learned from large-scale randomized clinical trials looking at drug therapy in people with heart failure with reduced ejection fraction, if you were to smush all the people involved in the study together, it would look like a mostly old, mostly white, mostly man, mostly with coronary disease. And so one of the biggest challenges for us is translating that evidence into practice for example, younger women of racialized communities. So it's a huge issue. One of the ways that we try to address that is through something known as pragmatic or real world evidence, where a drug becomes available because it's been proven in a clinical trial, and then it gets used in practice across a population of people. And then we use information contained in what are known as administrative databases. For us, that's the Institute for Clinical and Evaluative Sciences, which holds all of the data for anybody with an OHIP number in Ontario. And we can look at the efficacy of, or the effectiveness of those drugs in different populations. And so that is one of the ways that we try to understand the impact of drugs that have not been formally studied in women or other communities. In terms of heart failure with preserved ejection, there are more women represented in those studies, but still not as good as it should be or as good as it could be. And this is a huge issue, right? Half of the people who have heart failure are women, and yet we're not represented. And if we look at a city like Toronto, which is the most multicultural city in the world, we have South Asians, we have Black, we have Indigenous populations, we have many communities that are not represented. The same can be true for some of the less common cardiac causes of heart failure that are not also well represented in clinical trials. Those would be congenital heart disease, for example, and we could break down by congenital heart disease, or Heather, even ARVC. So one of the ways for us to try to understand that is to use these very large data sets and try to figure out if we react and respond the same way or not, and what the differences might look like in terms of side effects and effectiveness. I'm not sure, Mike, if you wanted to add anything to that.
No, it's hard to add to that. I mean, I think people recognize that it's an issue. There are pockets of excellent research that are growing, and we're getting a better understanding of the differences of heart failure and heart disease in women compared to men. And we're moving, what we've known for 10 or 20 years is that women develop heart failure typically at an older age. They're more likely to have better preserved heart function as a rule. But we're starting to learn a little bit more detail or granularity around the heart failure journey of women compared to men. I had seen this question submitted, so I wondered, what's new, what's out there, and just one example of a Canadian study done by our colleagues in Hamilton down the road was that, if you refer patients after discharge to hospital to a specialty clinic, it doesn't necessarily prevent being readmitted to hospital equally. It turns out that women benefit more from being seen in a specialty clinic after an admission to hospital with heart failure. Now, that's just one study. I thought it was a neat example because it's Canadian, but it's a good representation of research that's being done specifically to look at what's different about the heart failure condition and journey in women compared to men.
Well, so great answers. We have a question that came through, and I'll just bring it up here. What is the recent developments and research that you're currently really excited by and that could change the landscape? And so I'd ask maybe each one of our experts to weigh in on this. What really is exciting you and that you'd like to share with us tonight? So Heather, why don't we start with you? I know you're excited about things.
Yeah, so, I'm going to land on, what's being talked about a lot, which is the place of big data and artificial intelligence. And to me, this is one of the really exciting things that is coming in the field. And so when we were asked about, differences between men and women and differences in groups, some of what we can understand is down at a gene level and, proteins that you make and how those proteins are metabolized. And we can start looking at these vast quantities of data that we never had the ability to analyze before. The compute power or computer power now that exists is so much past. So one of our most exciting studies is the Apple Watch study. And we were getting data from these wearable sensors, these technologies. So we're getting all of this digital data, plus all of the clinical data that we understand about patients, plus all of these omic data. So the genes and the proteins and the metabolisms. And, in our first 50 patients, we have generated more data than we had in the entire last 250,000 patients that came through 1 year at the Petermont Cardiac Center. So I can't figure that. I can't do a statistics on that data. I don't have that ability. That requires massive computing power and machine learning scientists. But what they can look for is patterns in the chaos. They can look for patterns in that information that may allow us to predict earlier when somebody is going to be at risk for something happening in heart failure, at risk for hospitalization, or at risk for dying. And it allows us, I think, to change the way we deliver care from these episodes where we book you for a visit to on demand or at the time when you actually need it based on your personal individual information, because we've done the research to tailor the intervention to you, woman, man, old, young, coronary disease, congenital. So that's where I'm so excited. And, where I saw in the comment that's bonkers. It feels some days like it's bonkers, but it isn't. It's happening. We've got a ways to go yet for that to happen. And thank you. Yes, that's a great use of the Apple Watch. So one of the things we're looking at, for example, on the Apple Watch is your heart rate variability. And, we're looking at your fitness levels. That question came up earlier. We're looking at quality of life, Rob's territory, and what the impact. We think that might be one of the most impactful things on outcome is patient-reported outcome measures and how they describe it. But we've never kind of baked it all into one cake. And that's really what we're doing with machine learning, is pulling all of that information into one environment and then trying to come up with these predictive algorithms that we can help that learn as they go, so that we're learning from each patient as they come in to the program. So Heather, you've heard me talk about that. You know how excited I am. I think there's a real future there for us.
That's great. It is very exciting. So Rob, I'm going to throw this one over to you. Is there anything you're excited about in the mental health research and heart failure?
Yeah, I think I'd, sort of as an extension of what Heather was talking about, like to comment on this whole digital environment that we live in, as we see tonight, right? There's so much expertise in a center like the UHN, and it's been just a thrill for me to collaborate with people like Heather and Mike and Anne as well, in different projects. But also there's so much collective wisdom from people with lived experience. And to me, one of the most exciting ideas is to try to foster or to build a virtual community where all of this can come together. And that's what we've been trying to do in one of the projects we have going. Heather mentioned quality of life. It is a real passion of mine to try to see what we can do to enhance it as we look at the journeys of that everybody has through the course of life, and particularly when they're coping with challenges, that they face with heart failure. But it's that opportunity to have a virtual environment where you have, guests with particular expertise from the health professions, speaking with the insights generated from people with lived experience. I think that's dynamite. That synergy, I think, is really unique. And I think we're really on the verge of being able to do something very permanent and constructive in shaping the field of healthcare.
That sounds great. Tina, would you like to weigh in, or there's something?
Yes,
to say too?
please. Yes, because tying into what Heather said, and actually what Rob said too, I think that the Medley program, for anyone who is not familiar with it, it is our remote heart failure monitoring program, and it really is. It allows us to monitor you very closely at home and provide you with early intervention, and also, as a connection, as a bridge from you being at home to your heart failure team at the hospital. This has been extremely important, especially through COVID, because with all the changes at the hospital and patients, not wanting, we had to alter our outpatient visits to more urgent visits. A lot of our patients felt very isolated and disconnected from their heart failure team. So the Medley program has allowed them to stay connected through us. So by just monitoring your daily vital signs and symptoms, we have been able to just trend everything and really just get on top of any even small changes, and advocate to the heart failure doctors and the heart failure team, including if you needed a dietitian, social work, or had to come in to come into the clinic on a rapid basis. So I think that this is so exciting that the program is expanding, and I think it's really going to. It also helps us to health teach with the patients more on a personal level. When they come into clinic, they're with their heart failure doctors, but a lot of them leave with so many questions, and it also gives us a time to be able to really sit down and health teach with not only the patients but their families.
Get Great, thank you. So Mike, we're going to give you the last word on this, and then we're going to wrap up tonight's event. So anything that has you very excited about heart research right now?
Well, I mean, it's a pretty wonderful environment to live and work here, and you get to see what your research colleagues are doing. And just to build on some of the things that have already been said, one of the things we're going to try to do is leverage technology, digital platforms, to automatically adjust medications, so that rather than coming downtown Toronto and paying to park at the university health network and then coming in for a 15-minute face-to-face visit to get your medication dose changed, we're going to try to automate a lot of that, and we all have this instinct this is going to go well and really enhance the patient experience. So in one arm, we're really trying to deliver effective or efficient care, get the most people out there in the population looked after as best we can with the medications we know work. On the other hand, Heather kind of mentioned this really in passing, but I think it's worth emphasizing that the future state isn't to say that we've got the whole population on all of these medications and treatments. The future state, I think, is to say this person is going to do best with these 2 or 3 medications and this one, procedure, and that's going to be as good for them as somebody else who has to take 5 medications, or someone else who only has to take 1. So we're really going to get good at understanding which patients need to be on which treatments at which time. And that's going to be really exciting as we leverage all of this technology and research to figure out who gets what when, and we know why, because it's going to make people live longer and feel better.
Great, thank you. Okay, so that is going to wrap up our Q&A. We have an exciting raffle for all of you who've participated tonight. You have all been entered into a raffle to win one of 4 $25 Starbucks gift cards. So, well, those winners will be announced in a few moments. We have some things we'd like to tell you about. The first thing is very exciting. So we have a new patient and caregiver site, which will be launching this May during Heart Failure Awareness Week. It's called the Heart Hub, and it's for patients, caregivers, and their families to learn and connect with each other, to build community. And really, it's a knowledge center for you to come and learn more, especially if some of the questions you have not been answered tonight. So look forward to that in May. If you're interested in being a tester to see how the website works, you can email Samantha, and her email address is on the screen. We have another opportunity for anyone who would like to join the Writing the Heart Expressive Writing Workshop. It's facilitated by Dr. Shannon Bray. She's an author, educator, and heart failure patient. The sessions run for 6 weeks. It starts this Thursday, March the 3rd. It goes from 1 o'clock to 2:30 in the afternoon. And if you're interested in joining that, which I encourage you to do since Sharon is excellent, you can learn and register at the email address that's provided there. And Rob, if you could talk about the Odyssey VChat pilot trial, please.
Oh, thanks. Sure. Well, in Montreal, we're looking for people diagnosed with chronic heart failure to join a study. We have 1 study and 1 trial, but the intervention is the same for both, which involves having access to an automated digital program that has recordings by people like Heather and Mike and others with expertise on different topics about self-care for heart failure. We also have weekly meetings that are held as a webcast that's jointly hosted by a person with lived experience and by a health professional. And we address topics that cover the full spectrum, everything from mental health to pharmacy guidelines, to exercise, to diet, and so on. So that's it in a nutshell.
Great, thank you. So we're going to go to the screen that will give us the random winners, the name picker screen. Here we go. Okay. So Sanud, oh, I can't pronounce that last name. So if your name comes up, contact Samantha, and she will tell you the details of how to claim your prize. Jillian Macklin. Francisco Denaforio. And I think we got 1 more. And Meyer Battelle. So there's our winners for tonight. So I'd like to thank everyone for participating. It's been a great information session. I've learned a lot. I hope you have too. I'd like to thank our experts, Rob, Tina, Mike, and Heather. I'd like to thank my co-moderator, Sheila, and the organizers, Anne and Samantha, for putting this on. We hope that you've learned a lot. This won't be the last webinar we do, so stay tuned for more announcements. And we encourage you to check out some of the things we mentioned tonight, particularly the launch of the Heart Hub website. So thank you and good night, and thank you for your time.